Recording now. Well, welcome everybody to today's Learn at Lunch with Dr. Jeff Rich. I know Jeff's got some interesting case studies that he wants to show you and dialogue with you, so please make sure if you have questions to go ahead and speak up. Right now I'm going to have everybody unmuted, but if you're making noise in the background, just mute yourself and then unmute yourself if you have a question, just so we don't have to be distracted with that background noise. I am going to be sending you a link after the session with the recording and a 6-question test for those doctors in South Dakota that want to qualify for a continuing ed unit. So hang on just a second. All right. So with that, I'm going to turn it over to Dr. Jeff Rich. Go ahead, Jeff.
Well, thanks, Jeff, for the opportunity to do these cases with these docs. Welcome, everybody. We're trying some new technology, and I'm looking forward to having a format where we can be in our own clinics and yet be able to interact and ask questions. And I'm not really the kind of lecturer who likes to sit and tell you 14 different facts about fibrous dysplasia, because you've already passed all your multiple choice tests. And what I want to show you is some case studies and have you actually participate in those radiology case studies and kind of practice going through the approach of doing radiology. And what I mean by doing radiology is the 4 Ds. I teach one class at Northwestern these days. It's a fun class. It's for the trimester 9 students. It's all case studies. And we go through this process of radiology. We start with detection and just try to get them to discipline themselves, not to try to slam dunk the diagnosis right away, but to really just figure out where the abnormality is, to go through a flow, technical, alignment, bone, cartilage, soft tissues, not getting surge satisfaction, looking at all 4 corners of the film, really taking some patience with detection. And once they get to detection, everybody wants to slam dunk the diagnosis, and I'm trying to get them to slow down, to just be forensic about it. Just tell me what you see. There is a well-defined lucent lesion with well-defined cortical margins in the right proximal femur. And not to say fibrous dysplasia and try to slam dunk it, but just to describe it, because as they learn to slow down and describe, they drive themselves right into the differential diagnosis. And I always tell them, try to get 3 things. Number 1, what do you think it is? Number 2, what's something it could be that looks like this? And then the 3rd thing on their list ought to be something that could really hurt the patient if they didn't think of it. Something that might look like this, maybe not exactly, but I should at least think of it. And then the whole point, decisions, decisions, decisions. How does this x-ray diagnosis impact the patient care? What do I need? Is there anything I need to do with plain film to figure out what it is? Advanced imaging, blood work. But more important than all that, if this diagnosis, what is it? How does it change anything? What are the associations and complications of this disease process that helps me for Monday morning? It's like Paget's disease. You say, who cares? Who cares it's Paget's disease? Here's why you care. Because with Paget's disease, you have high output cardiac failure, you have high incidence of osteosarcoma, you have weakening of bones, bowing of bones, cranial stenosis, spinal stenosis, and basilar lung fibrosis. And the only way to know those associations and complications is to have that label, Paget's disease, you got from the plain film, and plug it into Google. And everybody wants to know that information. I'm trying to teach the students at the school this flow of doing the Ds. Okay, so that's kind of what we're going to do, and I'm hoping it works for you to be able to chime in and have some fun trying to find these things, and then we'll just talk about the cases. So I'm going to get going right away. First case is a 52-year-old with pain. It's not much of a history, but that's all I had. That's all that the doc sent in to me. So there it is. Here's the first picture. All right, AP lumbopelvic film. So I'm going to shut up now, but here's what I want you to do. I simply want you to find the area of the film that in your right brain looks, that just doesn't look right. What's going on there? Don't worry about what it is. I don't know either, frankly. Just tell me where you think the abnormality is. Okay, so anybody wants to start talking and shout it out, go ahead and do so. Otherwise, I'll just do it myself and tell you what I thought was strange.
Just to the right of the lumbar spine and into the pelvis.
Excellent. Okay, I agree. So, and that's all we need for detection. You know, just to the right of the lumbar spine, that's the right, into the pelvis. So right in here, our right brain says, "What in the world?" And very good. I agree. All right. So let's take it the next step. I agree with the detection. Let's ask the hard question. Do we think that the finding is in the bone, is in the soft tissues, or is perhaps in both?
Need a lateral view.
Okay. I don't have a lateral view that I saved for you, and it didn't help a lot, but very good. You got it. If you're going to detect this stuff, especially in the soft tissues, you need a lateral view. So let's just go on. Let's just work with this one view just for fun. What do you think? Bone, joint, soft tissue, everywhere.
Both.
Both.
I agree. Okay. Both. Yeah, I'm with you. I said it looked like both.
Hello?
All right. Everybody hear me okay?
Can you hear me?
Yes, I can.
Again, Wayne.
Okay, great. Thanks.
Yep, I can hear you. All right, so let's throw out some of the detection. You've done the detection description. What are some words, if you were forced to write a radiology report and describe what you see, what are some of the words you might use here?
Expansile lesion.
Okay, lesion. What kind of lesion?
Expansile lesion.
Okay.
Radiopaque.
I love it.
Osteolytic.
Okay, there's some regions of lysis. All right, so if you were to commit, everybody, would you, with the words expansile, lesion, opaque, and lysis together, would you favor in a 52-year-old with pain? Would you favor something that's non-aggressive or aggressive here?
Aggressive.
Aggressive.
Yeah, I'm with you, and I did too. All right, good job. Let's tell you what the answer is. You did it. A right ilium aggressive lesion, and I believe that there was some question of some soft tissue expansion, but you know, plain film is what it is. The lateral view, yeah, it didn't help much, but I thought that that's what it was. And here, it's so recent. I'm giving you all the cases from my practice because it's way more fun. And this one ended up being an aggressive lesion. And they're still trying to track down the exact needle biopsy. But on MRI, the diagnosis was probable chondrosarcoma is number one because of the soft tissue mass and the bone destruction in a flat bone. But really, anytime we have an aggressive lesion, we still got to always put metastatic disease on there. Osteosarcoma doesn't work as well because that's going to be more in kids. But what I wanted you to hear is just to find it and to think whether it's aggressive versus non-aggressive. All right, as a group, we are 1 for 1. All right, good job. Next case. 34-year-old female with anterior and posterior neck pain. Okay, that's our history, anterior and posterior neck pain. All right, here's a really hard detection case. All right, so detection, I'll tell you what, this is the kind of thing that if I could wire over a $10 gift to you for an award for making the finding, you would win something here. but just for fun, let's see if anybody can make the finding here. Go ahead and look. Technical, alignment, bone, cartilage, soft tissues. Don't get search satisfaction. Look at all four corners of the film. Anybody have a guess for me?
Is there a decrease in the anterior airspace?
Wow. Okay. What's your number? Let me wire you some cash because you are.
Oh.
Now take a look. Good. Take a look here. Let's color in the retrotracheal clear space. You know, we learned in school that that should be less than 2 centimeters. But we also learned that at C2, that space ought to be less than 7 millimeters. And of course, this retro space here ought to be less than that. But as point of fact, if you look at it, the retropharyngeal soft tissue space is actually greater or as great as the retrotracheal soft tissue space. So you're right, guys. That is strange. Now, what's interesting here is, you know, why is it strange? Well, you know, I like to tell my students to come up with a differential diagnosis. They can use cat bites or some sort of acronym, but a real good one just to get the ball rolling is, why is the retropharyngeal soft tissue space big? It's either hemorrhage, abscess, put on your hat, hemorrhage, abscess, trauma. That's a great differential to get you right 95% of the time. So in this case, it's sort of violates that rule, but it's similar. If you look here, and I'm going to try to blow this up for you so you can see it. Now, if you look here, you can see the anterior arch of C1, but right below that, you can see like a ghost opacity. It's almost like another anterior arch, kind of like almost a double exposure right below that. Do you see that? That is strange. Now, many of you have seen calcification right underneath the anterior tubercle of C1. And calcification right under the anterior tubercle of C1 is called longus colli calcific tendinitis, which is hydroxyapatite dihydride deposition disease. And in this case, it is so acute, guys. It is so much of an acute case of calcific tendinitis in the longus colli musculature that the calcification is super indistinct, so indistinct that you can barely pick it up on plain film, and it's causing inflammation and swelling into that region of the muscles. Okay, so this is probably the coolest case of longus colli calcific tendinitis I've ever seen. And you can barely see it on plain film. You say, well, what does this mean for, oops, hold on a second. Find out what happened here. Hold on, let me get back and see if I can get this pulled up. Okay. Come on.
While you're doing that, just as a side note, I had a patient once that had severe neck pain, and when I moved the trachea back and forth, it caused extreme pain, and it ended up being an abscess in that area.
Yep, that's a great thought. In fact, with this kind of swelling like this, abscess, hemorrhage, abscess, tumor, hat, that's a great thought. This one ended up being calcific tendinitis, but look at the inflammation, guys. Here's the treatment for this. It causes fullness in the throat, difficulty swallowing, intense pain. But the good news with calcific tendinitis, if you can make the diagnosis on this, is it's self-limiting. So if you treat conservatively, sometimes ultrasound, ice, and time, the swelling will go down and the patient will be just fine, and that's what happened with this patient. So it's a pretty nice case. Pretty nice case. All right, longus coli HADD. Next case. 23-year-old female with severe pain. All right, and I will give you a little more history in a second.
Hey, Jim, just as far as the history people give to you, do you want more than that?
That's a great question. You know, we have these forms that, you know, you fill out, and you guys are busy and we're busy. So what I want is just enough information that you think is pertinent to the case. So when you check a box, there's no history of trauma, that's helpful. There's no history of cancer. But the thing that really scares me that I want to know is there, like, the patient's not responding to care? You know, that gets me fired up, because if you think it's a sprain strain and they're not responding to your care, then either you're not very good at what you do, or there's more going on here. And it's almost always the fact that there's more going on. I know sprain strains can take a while, especially with certain whiplash injuries, but I'm telling you, if they're not getting better at all, that's a red flag. So I don't want to book just one sentence of pertinent history and some things like, you know, like, is there trauma? Is there cancer in this patient? Are they responding to your care at all or not? Those are the key things. All right, check out this. This is a really good open mouth. Oh boy, getting nervous here. Okay, this is a really nice open mouth. And I want you to look at it under detection. And just look at and see if you can make a finding on this open mouth.
The atlantodental space wider on the right, or whatever that, I can't tell if it's right or left now, because I don't see anything.
Yeah, I don't know why the films are coming off. So we'll have to figure that out for the future if I'm going to use my tablet. I could just use a regular PowerPoint if we need to. Yes, so if you look at the left here, this atlantodental interspace and this lateral atlantodental interspace, big difference. However, the two front teeth and the occiput are really lined up pretty well. So a lot of times it's just that they were rotated significantly during positioning on setup that kind of fakes us out here. In this case, I felt that the alignment on setup was pretty good. And so that's good. The most important finding here is that asymmetry in the lateral atlantodental interspace. So we go then to the lateral view of this patient. Okay, take a look at the lateral view. Now, of course, we're looking in the upper cervical complex here. What do you guys see? What do you guys and gals see? Anybody see something else here on the lateral view? Of course, there's loss of the lordosis, but look further than that.
Like that atlas is rotated or separated a bit.
Okay.
Everything else can superimpose.
All right. Right, good. That is true. If you look at the jaw, if you look at the angle of the mandible, it's beautifully superimposed, which is rare. So we know that there's not a lot of rotation during positioning here. Yet we see back here that we see the posterior aspect of the lateral masses. They're offset a little bit. So we see some more evidence of rotation of C1 on C2, but what we like to see here, what we're happy about at least, is the anterior atlantodental interspace is within normal limits. Now, but don't get search satisfaction here. Technical, alignment, bone, cartilage, soft tissue. Look all the way through to the soft tissues. And what do you see?
Anterior swelling again.
Yeah, and because because we just saw it, we say to ourselves, he's not going to show me 2 of these in a row. And because we already made a finding of rotation, we tend to say, I've earned my paycheck. I'm not going to, that's my finding. When we need to keep looking, and I am with you. Look at that. In front of C2, it's swollen again. And again, here is hemorrhage, abscess, tumor. Well, let me give you a history here. There's a history of trauma in this case, a car accident, a pretty bad MVA. All right, put this all together, docs. You have a big retropharyngeal soft tissue space. You've got rotation that's real of C1 on C2. What do you think the best diagnosis is once we've now identified the findings and we've described them?
Fracture the atlas.
Okay. Did you say fracture of the atlas?
Yeah.
Yep, that is on the list. Fracture of atlas. What else?
Atlantoaxial instability.
Okay, atlantoaxial instability. Okay, so we didn't necessarily see a broken bone here, although with trauma, we're going to want to get a CT and maybe an MR. I'm going to probably start with an MRI on this case. But we know for sure that we have atlantoaxial instability, that C1 is rotated on C2 enough, guys, listen, that it's bleeding out. There's blood. There's blood there. And so what prevents C1 from rotating on C2? Well, the ADI space is okay. That's nice. The transverse ligament looks to be intact. Well, what other ligaments are there that kind of check rotation of C1 on C2 and the occiput in C1 in their alignment?
The alar ligament.
Yeah, bingo. Guys, here's plain film evidence of apical alar destruction. Great case. So follow-up is to get an MRI, high field, none of this 0.3 Tesla junk. At least 1.5 Tesla of the, and I always tell CDI, hey, I want upper cervical trauma sequences. I want you to image, slice through those apical and alar ligaments with a high magnet, because I think they're gone because of what I see on plain film. Yeah, go ahead and get the rest of the cervical spine, but I want upper cervical protocol, I call it. Upper cervical protocol because of what I see on plain film. So good call, guys. Your guys are 2 for 2. Let's get on to another case. All right. Pain and diminished range of motion, and the doctor suspects supraspinatus issues. So I think we've got a shoulder case. Yes, we have a shoulder case here. All right, detection again. Detection. Okay. All right, what do you see here?
The distal acromion looks a little off.
Good. Very good. The distal acromial process looks indistinct. Very good. And we're going to pick up some speed here. In the acromion, if you look at it, notice that it looks like it's actually split right in 2. Isn't that strange on the baby arm view? That's why it looked indistinct. And it's got well-defined margins, so it's got to be chronic. It can't be a new thing. It's got to be an old process. And this ended up being what's called an ossicromial. It's an ossicle. It's an ununited secondary growth center of the acromion process. It makes the acromion process look indistinct, but on the baby arm view, sometimes you can capture the lucency. The significance of this os acromial is the bulkiness around that, where that comes together can cause a narrowing of the acromial humeral space and impingement on the supraspinatus muscle. So it's a nice case of an osteochromial. It's been there a while, causing supraspinatus problems. Okay, here's an injury that occurred kicking a soccer ball. Okay, in a kid. All right. Pain's on the left. Okay, pain kicking a soccer ball. You know, when I blow it up, it tends to go white. So I'm going to not blow it up for the rest of this talk and figure out why that is. See if I can go back. All right. So take a look at this. Pain's on the left, and it hurts when this kid. We know it's a kid because we've got look at the iliac apophyses are not united.
Probable avulsion of that ASIS.
Excellent. You guys are good. So we know there are muscle insertion sites all throughout the pelvis. Obviously, the gonad shield's covering up where the hamstrings insert. We know that the rectus femoris inserts into the anterior inferior iliac spine. The rectus femoris is there. The hamstrings are there. But here is the anterior superior iliac spine. And if you compare the right with the left one is pulled away slightly. You see that? And so there's a muscle that inserts there, sartorius. The sartorius muscle inserts at the anterior superior iliac spine. I call it the hacky sack muscle, but it's definitely used a lot in soccer, and this is an avulsion injury at that muscle insertion site. Good pickup. 3 for 3 or 4 for 4, whatever we are. I think 4 for 4. You guys are on fire. Okay, next case. So an avulsion at the anterior superior iliac spine at the sartorius muscle insertion site. Okay, persistent back pain and history of surgery. Persistent back pain, history of surgery. All right, so this is a little bit of a harder case, maybe, but you guys are doing well so far, so go ahead and let's find it first. Where's the finding?
Got a compression fracture, that upper dorsal spine, right behind the humeral head, it looks like.
Okay, so it's really tough to tell, if that's compressed there or not. I'm with you. It might be. I think we'd almost need a swimmer's view to tell for sure. Keep looking at through the rest of the spine. There's another finding. That might have ended up being bad in this case. Keep looking.
L2?
Yeah. Okay, so I'm just going to say right up here doesn't look great. Yeah, I mean, look at it. It doesn't look right. There definitely right here is loss of anterior vertebral body height. There is a compression there. Do you guys buy that?
Yeah.
Now, do you think that this looks aggressive or non-aggressive? Does the bone look healthy or non-healthy?
Does not look healthy.
Yes, I buy it, and I think even this level, it looks lucent, and then this level, it looks lucent right in here, and then there's a compression fracture, and so I don't like it. I think this looks like an aggressive lesion affecting a couple of levels with probably a pathologic compression fracture. Now, if I tell you here, look at this. There are surgical clips superimposed on the upper lumbar spine. So what organ probably was involved then if it's superimposed on the spine? Retroperitoneal.
Kidney.
Yeah, kidney. So let's put this together. They have kidney. They have kidney cancer. They had the kidney removed, and it has gone Mets to the spine, affecting a couple levels. and patient had no idea that they had metastatic disease. They just had back pain. Now, I agree that it looks a little questionable up there. We got an MRI of that whole thoracic spine and lumbar spine, as well as a bone scan to follow up on this case. But it's a great example, I think. It's a sad case, but it's a good example of not just compression fractures from trauma and all of that, but to be reminded of pathologic compression fractures. Good pickup. Renal carcinoma with Mets to the spine is the final diagnosis. All right. Come on now. Come up. Cases. Well, Jeff, if you're there, this is working great, but for whatever reason, I'm having a little bit of a hard time sometimes pulling the cases up towards the end. So it's one thing I'll have to work on if I'm going to use this technology, because we can't have it do that. Okay, next case. All right, sledding injury, maybe next case. Okay. All right, well, let's see, guys.
Can you just keep it minimized like you had it before? There.
Yeah, I'm hoping that we got it going here, but we're getting close to closing, but this is definitely not what we want here. There we go. Okay, take a look at this while it's up. Here's a sledding injury with pain in the thoracolumbar junction. And again, another compression fracture here. But on this compression fracture, you know, the bone looks pretty good, but you got what's called a step sign at the anterior-superior corner. You've got increased sclerosis right underneath the end plate. And so do you like this one for aggressive or non-aggressive with a history of a sledding accident and this finding? Aggressive or non-aggressive, or regular compression fracture? Yeah, non. And next question, do you like acute or chronic with that sclerosis and with the step sign up front?
Chronic.
Okay. If you see sclerosis on the underneath the superior end plate and a step off that corner of the end plate, it's radiographic evidence of an acute compression fracture. That's radiographic evidence of an acute compression fracture. So we know what a pathologic compression fracture is by way of reminder. You know, the bone density is bad. Then we're worried, and we have a history of cancer. Here we have trauma, and we have a step sign and a zone of condensation, which indicates an acute compression fracture.
So you're saying that it's the step sign is what makes it acute, not the sclerosis. Or are you saying even the sclerosis makes it acute?
Yeah, great question. Both the sclerosis, that zone of condensation, it's called, right underneath the end plate, and the step indicates acute. And what's happening is when it smashes down, it's like the trabeculae are getting real close together, and that just makes it look opaque, like an impaction fracture might look. And after time, the body kind of clears out the debris, and that zone goes away, and the step kind of rounds out with a more chronic traumatic fracture. So it's a beautiful finding. If you see that step and that zone right underneath, that zone of condensation right underneath that, it's a pretty much 99% acute compression fracture. It's a great pickup. It helps you when you're, sometimes you go to litigation on these cases, and these things really help bail you out, these little findings like this.
So would you MRI that to confirm that or no?
In my opinion, I would, and here's why. Here's why. Because if you look with me, the height of the posterior vertebral body is a little bit down compared to the level below. You guys buy that?
Yeah.
Not a lot, but anytime you lose a little bit of the posterior vertebral body height, that is the definition of the potential for instability. You know, that there could be a retropulse fragment, or there could be problems with the posterior longitudinal ligament. And I would like to prove that it's new, but I also want to see if there's any kind of a retropulse fragment. So yes, MRI is what I would do, not because am I not sure if it's acute or chronic, but because there's a little bit of loss of the posterior vertebral body height. Does that make sense?
Yeah.
Okay. And all I can do is apologize that these cases aren't coming up. It's really annoying to me. So I'm going to just try something else here. Because this one did come up from a different case. So since we only have a couple minutes left and that one's not come up, let me just show you a different case. Check out this ankle. Is that not nasty or what?
Wow.
That is nasty. All right. So what's your, what are some of your, I mean, everyone sees it. So let's go to a DDX here. What are some of your thoughts for this horrific looking ankle? Just start throwing them out there.
Infection.
Right. Excellent.
Then obviously some inflammatory arthropathy.
Yep. Okay. Inflammation.
And then just DJD.
Right. And DJD, that's pretty bad. That's DJD with a vengeance. All right. So let me give you a little history. They have tingling in their hands and their feet.
Yeah.
Diabetic neuropathy.
Very good. Diabetes. So I agree. Infection, DJD with a vengeance, maybe rheumatoid that you walked on and pounded, but they don't feel the joint. And this patient had a Charcot's joint. They had a neuropathic joint, and they pounded it. And one of the worst cases of a diabetic ankle I've ever seen. In fact, it didn't hurt, and they actually had fractured their ankle as well. Can you see that lucency there?
No.
Through the distal fibula is fractured as well. So you've got a diabetic foot here with the 6 Ds of Charcot's arthropathy: dislocation, debris, distension, dislocation, density. It's just nasty looking. And when I see something that looks this bad, I really think of infection and diabetic neuropathy as my first 2 choices.
So with the Charcot foot, is it because they lost their sensation that they traumatized it enough to fracture it and then it just kept active on it, or what causes the changes?
Yeah, that's a good question. It's that they have lost their proprioception and their feeling in the joint, and when you lose those, you lose mechanoreception, and so they're having just normal walking is causing asymmetrical loads. They get little micro traumas. They don't feel it. They absolutely abuse their joints, and they can't tell it.
No.
It shows us how much we have to offer our patients in restoring proprioception and mechanoreception for good joint function as chiros. I mean, because this is what happens if you don't have it. You trash your joints. Absolutely trash your joints. It's crazy, isn't it?
On a side note, just of interest, apparently that's what happens with lepers, with the leprosy. Is
Yes.
They lose the nerve sensation and their tissue, everything just gets so traumatized. That's the visual injury you see, but it's not that the skin's actually falling off from bad skin, we could say.
Exactly. And in fact, it's diabetic neuropathy, and neuropathy from leprosy can look indistinguishable on plain film. I just didn't have it on my list because it's way more rare, but it would look the same. It would look the same. The mechanism is the same. All right, Jeff Smith, are you still there?
I'm here.
It's 3 minutes till. Are we good? Do we get enough?
Yeah, I guess at this point, does anybody have any questions relating to the case studies that Jeff showed, or any other questions that now that we've got him on the line?
No, do we want to try to do this every month or something, Jeff? What's your intent with this?
Yeah.
Go ahead,
Jeff.
Jeff. Yeah, which Jeff? Yes, that's in the plans. Yeah.
And I think I apologize for the technology, but tell me this isn't cool if I can get it to work. You know, with the idea of being able to write and expand it. So I'll work on that from my end. If not, we'll go back to the old PowerPoint. But I think the tablet can be a real big help for this kind of distant stuff.
Right.
I'm thankful that it didn't start freezing till the end. Let me Jeff, if you can give me a couple more minutes.
Yep.
Because of the freezing here, I just want to pull one thing up. Let me just pull up one more case that they can gander at, because I want to show you the lateral view, guys. Isn't that impressive? That's the lateral view of the case that I just showed you. So take a look at that. I'm going to pull up my other computer just for a second.
So as he's pulling that up, Jeff, I would, Smith.
Yes.
Being live is going to be better than the tape because of the interaction.
Right.
But this is excellent. This is of great value and is definitely worth what we paid for it today. But a fee in the future would be very reasonable. And this is as good a webinar as I've listened to. So excellent.
All right.
Good.
Here's my takeaway. Between all of us doctors, we can diagnose darn near anything. None of us got 100%.
You know, I'm impressed. You know, we put our heads together, and it's amazing what we can get at, what we can get. Take a look at this. This is great. Look at this. I don't know if you can see it, but there's some soft tissue atherosclerosis of a vessel superimposed on the calcaneus, which can happen in diabetes. So it's a fun little finding. All right, let me help you here, guys, because I'm going to, let's see here. I got to make sure about one thing. Any other questions for me while I'm looking one other thing up?
Jeff, while you're doing this is Jeff. I'll when I send out the quiz, I'm going to send your contact information with it too. If people aren't using your services right now, that we'll give them that information, that if they want to, then they have that.
Okay.
Hey,
all right.
Jeff Rich, I just got in the mail. Are you doing a seminar October 14 and 15? It's like putting it all together or something like that. Are you guys doing that at Northwestern?
October 14th and 15th?
Yeah, you look for your stuff. I'm going to grab it real quick.
I don't think I'm up to bat then, but there is a seminar that weekend, I believe, in Minneapolis, and I am I take it back. I am teaching.
Yeah, you're there from 1 to 2.
Yeah, you're right. You got it. Thanks for reminding me, because I might not have showed up.
Yeah, you better show up. Yeah.
I just had a moment there. Yeah, I'll be there for an hour.
Yeah.
So do you think that it looks pretty interesting? Is it supposed to be a pretty good seminar? You don't know a whole lot about it yet.
I don't know a whole lot about it. I volunteered to just do an hour of it. But I can tell you that the group of people putting it on have always put on a really good show. The guy who got me going, he's a chiropractic radiologist, and they're into stuff that's going to be a help.
Yeah, look, well, the Yoakum, I'm assuming him and Cox are who probably got it together as part of it. So, yeah, okay.
Yeah. Hey, Jeff, can I make one comment before we go?
Yes.
Okay, guys. there's one question on the quiz that I'm going to give you the answer for because of the technical, it was my next case, and because of the glitch, I couldn't get it done. So please take this down if you want to get this quiz question right. The other ones will be easy because we talked about them. They're right from the cases, super easy. But number 6, I had a case of diffuse idiopathic skeletal hyperostosis that I didn't show you. Dish in the cervical spine, right? And my question was, which of the following are associated with diffuse idiopathic skeletal hyperostosis? You guys know? Just let's just, diabetes. What else? One more.
You want me to list, why don't you list the possible options? And then,
All right, here we go. The options are, number 1 that I put is ossification of the posterior longitudinal ligament, or OPLL. Number 2, osteosarcoma. Number 3, high cholesterol. Number 4, hypermobility. Which of those are associated with diffuse idiopathic skeletal hyperostosis?
Be calcification.
And the answer is
Cholesterol.
yes. Yeah, the answer is no. Diabetes would work, but the best answer is ossification of the posterior longitudinal ligament.
Yeah.
And I'm just telling you that because you don't deserve to get that one wrong because I didn't cover the case. So that one is put down OPLL for number 6, please. Okay?
all right.
Excellent.
All right. Thanks, guys. Jeff, anything else, you can call me afterwards and we can debrief and try to get the technology working good. But I hope I can do this again and get the glitches worked out because it's pretty cool.
Yes, well, thank you for your time, Jeff, and your information, knowledge. Thanks for sharing, and we'll be in touch.
Yeah, the only thing to say the last second here is, we do read for South Dakota docs at the school. We got great monitors. We can set up a digital tunnel so you can get feedback in 5 minutes, not 5 days. And so just we can talk more about that in the future. But we got to go now. But yeah, I'd be happy to help you guys if you have questions on your cases too.
All right. Thanks, Jeff.
All right.
Thanks, everybody.
All right.
Thanks.
See y'all. Take care.